Наступна доповідь Арман Hakobyan з Вірменії. Endoscopic Transforaminal Lumbar Disc Surgery.
So, hello everybody. Is it okay?
Listen you. You can start.
Okay, perfect. Perfect. Good afternoon, dear colleagues. I am Arman Hakobyan from Yerevan, Armenia. I am working in medical center, and my speech will be about. But before, I would like to thank the conference organizers and especially my friends Vladimir Radchenko and Valentin Piankovsky. Thank you for your invitation. So, as I mentioned, but there is some problem with that. Yeah. I'm working in a neuromedical center. It's a small private clinic. We perform different types of minimally invasive brain and spine surgeries. We performed about 400 spine surgeries per year, and mostly it was lumbar disc surgeries through the transforaminal approach, endoscopic transforaminal lumbar disc surgeries. So in a few words, I would like to demonstrate the history of development of the transforaminal endoscopy surgery in our department, because the way was paradoxal. I mean that we start from the difficult type of surgery. 20 years ago, I started with the transforaminal, and after 10 years, I continue with the tubular system. So for the people who want to start the transforaminal, I will suggest to start with the endoscopic assistant surgery, and after the years, continue with the transforaminal. We have now more than 1,000 cases, and I can remember that in the first period we performed the surgeries under the CT control. The duration was about 4 hours. There was a lot of complications, but now we are very friendly with this method. The duration of surgery is about 30 minutes or maybe less. We perform under the general anesthesia, under the intravenous anesthesia. So now it's very, very good type of surgery for me. In a few words, I would like to remind the people who were the pioneers in this field. Let's remember that about 100 years ago, Mixter and Barr performed the first laminectomy and published it. About 50 years ago, Kambin and Hijikata performed the percutaneous nucleotomy. And during the past 20 years, the development of the endoscopic technique and instrumentation, I think, give us opportunity to say that the visualization during the surgery is the same. Endoscopic and open or a microscopic surgery, if you have good instruments, you can say, I can see everything. I hope you will agree with me. So let's start with the basic knowledge in this surgery. Of course, we know that the most important point for the start is where is the point of incision. It was located laterally from midline from 10 up to the 14 centimeters because we want to pass through the foramen, through the Kambin triangle and reach the hernia. But for the lower lumbar discs is a difficult because crista iliaca closes the direct surgical approach to the levels L4, L5 or L5S1, so the incision must be done upper than the crista iliaca. Then we know that we must pass through the Kambin triangle through the foramen to reach the hernia, like it is shown in the right arrow. I performed this CT just after the surgery to show how we drill, how we perform the surgical approach. And the next important thing for me is the good understanding what we want. Where is the hernia? To merge the MRI picture with the X-ray picture in your mind, like this. We know hernia is here, so you perform the surgical approach and put the cannula and the forceps just on the hernia. Similar on the anterior-posterior view. The hernia is here, so we have only one chance to drill the correct surgical approach, and it must be done correct, just on the hernia. So for me, it is the important point of the surgery. Good imagining, merging MRI with X-ray picture in your mind, and drilling correct surgical approach. After it, we start with the Tomshidi needle hammering. we must reach the border of the disc on the lateral view, not to go into the disc, and on the anterior posterior, we reach the lateral border of the canal, is the correct position of the tip. After it, we continue with the drilling. You see the drills go a little bit deeper into the canal and reach the midline on the anterior posterior view, but on the lateral, they reach the disc border and don't go into the disc. It's the correct position. After it, we of course continue with the cannula and the endoscopic step of the surgery, but before it, I would like to share with you my idea about the manual drilling. Years ago, we made manual drill and named it Discobur. Advantage is that the tip of the drill is larger than the diameter of the endoscope working canal. So we can input it, connect the handle, and we have the manual drill with the endoscopic control, and we can perform drilling the bone structure if there is a need. I don't use this instrument all surgeries, but sometimes you need something like this to drill the bone, to open the way for the forceps to continue the surgery with the discectomy. And as I mentioned, we continue surgery, input the working cannula, again check the position of the working cannula like this. It's a hernia and the working cannula is in the right position. So after it, we go with the endoscopic controlled discectomy. So as I mentioned, very good visualization with the new endoscopes. You can visualize the hernia, the nerve root, and perform the extraction of the hernia without any dangerous. And if in the end of the surgery we see the nerve root like this, full decompressed, it means that the patient will go home without any pain. It's a main technique, and usually we can say that it's for the foraminal hernias. But I want to share with you two clinical cases and say that we can use this technique not only for the foraminal hernias. We can use this, for example, for the sequestered hernia like this. Level cranial sequestered hernia on the level of 3. And of course, we start the surgery with imagining where we must drill the surgical approach. Then continue with the thumb shidi, with the drilling. I use the drills from the 4 up to the 9 millimeter in diameter. And after it, cannula was inserted. We check the position of the cannula is the correct in both anterior, posterior, and lateral views. So after it, go with the endoscopy. Of course, we can visualize the hernia, and sometimes we can catch and extract big pieces. For example, like this, during this surgery, we extract 2 big pieces. Total length is about 4 centimeters. So the big sequester is not contraindication for this type of surgery. I think it's an indication for this type of surgery. And compare MRI before the surgery and after, you can see that the hernia is totally extracted. And the same on the axial view, hernia, everything is okay. Next clinical case is the patient with extraforaminal located hernias. For these patients, I think this technique also are very good because we can catch the hernia and extract it without any problem. We don't need drilling. You see the position of the cannula is more lateral on the lateral border of the spinal column, not on the lateral border of the spinal canal. So just on the hernia, again, check the position of the hernia. Yeah, it's here. Check the position of the cannula, it's correct. And the anterior view, everything is correct. And after it, we perform endoscopic extraction of the hernia in a one big piece. So with this, I can say that we can use this technique for the sequestered hernias, for the foraminal hernias. And the question, can we use this technique for medially located hernias? I think yes. Why? Because take a look on the video. the tip of the forceps, they reach the middle part of the disc on the lateral X-ray, and in the same time, if we see on the anterior posterior, they cross the midline and reach the contralateral border of the spinal canal. It means that we can reach and extract medially located hernias also. Next question, what we can do with such big sequestered? What is the problem? There is a risk that you cannot extract whole the sequester through the cannula with the inner diameter 8 millimeters. For this, we perform double surgical approaches through the one incision. One incision, at first we drilled one surgical approach, go to the lateral part of the hernia, then perform and drill the second surgical approach to the upper part. And we start the surgery, for example, from the lower part and then go to the upper part. This gives me opportunity that I can say I visualize all the length where the sequester was and I extract all the sequester. It's option, but sometimes I do this. So if we compare or think about the results or compare with the open surgery, I think we'll agree that results are the same. Of course, in the first period, we have a lot of patients with the problems like I don't know, liquoria or nerve damaging, but with the experience, with the years, the rate of the complications decrease. Now we perform this type of the surgery and the complications are very rare. About the advantages, yes, it's very minimally invasive, very good cosmetic effect, one-day hospitalization, but for me, the great advantages are the following. We can perform the surgery, the patients whom the general anesthesia is contraindicating, and the next question, that we can perform the surgery, the patients who took anticoagulant medicine. Sometimes we have patients who took the anticoagulant medicine and come to our department with the pain, drug-resistant pain, and we perform this surgery in the same day. I haven't any problem with the bleeding or a postoperative hematoma. So I think it's a good option for these patients. And of course, it's a minimally invasive. We can compare MRI that we perform after the surgery with MRIs that people perform after the open surgery, and we'll see there is no muscle damaging, there is no muscle atrophy, there will be no back pain after the surgery. I think sometimes the radiologist who performed the MRI cannot identify that this patient had the surgery previous. It's also a big advantage. These advantages, I think, are the following. It needs time, it needs experience to become friendly with this method. Yes, of course, there is a risk of nerve damaging during the drilling, especially if you perform the surgery under the general anesthesia. But in our department, these complications are very, very rare. And that's all that I would like to share with you about this technique. And in the end, I want to introduce you such interesting picture of the black disc, black hernia. I had this patient about 7 years ago, and during the surgery, I saw that the disc is black. At first, it was very terrible to understand where I am, what I'm doing. But then I read in the literature that it is a rare genetic disease, alkaptonuria. So if you see this black disc during surgery, don't be afraid, it's okay. And in the end, I would like to say that I miss my Ukrainian friends, and I hope that in the future we'll meet again in Ukraine. Thank you very much for your invitation. That's all.